we have phenomenally weak data collection and management processes in healthcare right now. And then when we do collect data, we collect it in a way that it's very hard to have it tell us anything meaningful. Or a lot of times I see organizations, if they don't like what the data is showing them, they're still engaged in that old school behavior that says, well, let's repeat the study.
Welcome to this podcast titled Saving Healthcare, where we talk about the current issues plaguing the healthcare industry and different ways to fix them. My name is Nicole Travis, and I'm here with Darlene Bainbridge. Darlene has nearly 50 years of experience in the healthcare industry, ranging from a frontline caregiver, a quality director, a risk manager, a risk consultant, a CEO, and a board member. If you've ever heard Darlene speak, you've probably heard her say that you need to monitor and manage quality and money like they're two sides of the same coin. So I'd like to spend some time talking about that today and what it means when you hear somebody say that they are focusing on the illusion of saving money. So, Darlene, can you spend a little bit of time talking about what the just culture is? Because I think that plays into this topic, and it's important to understand that from the beginning.
It does. Everything we've talked about so far up till now inside the different podcasts we've done all play to this. I mean, this is one of those situations where we can no longer just do little things and expect big results. We have to now bring it all together. We have to bring together systemization with a just culture. We have to bring together the whole concept of no longer grasping for salvation like Jim Collins describes. It's now got to be this more strategic, holistic approach to fixing what hurts healthcare and haunts healthcare, because it doesn't live in the little teeny tiny projects and ways we have historically done things. And so one of the most important things right now our hospitals have to think about is this whole concept of the illusion of savings, because we have to get control of what it means to manage the bottom line of our organizations in healthier ways. The illusion of savings is something that has haunted healthcare for a long time because we make a lot of cuts on the quality side of our organizations to create the illusion that we're saving. And because we never track the data and the measures, we have no idea how much we're really losing until those final numbers come in. And a lot of times by then it's too late to fix it. We've done enough damage that we cannot go back and undo it. It's not like it used to be. I mean, I remember a time where if we didn't get something right or we just didn't manage something very well, there was enough money floating around out there in healthcare that we could make up for it. We could just go out and add another service, or we could do something that would somehow work for the bottom line and we could fix it. We can't anymore. There's not enough discretionary money floating around out there in order for us to just fix things without actually fixing what's hurting us. So the illusion of savings, one of the best examples I think I've ever experienced was one where I was working with this hospital. They brought in a new CFO. And so the CEO asked me to work with the CFO on some ideas he had on how they could reduce costs. And so one of his ideas was he was going to drastically reduce overtime costs in all of the associated clinics. And I said to him, I said, okay. I said, so we wanted to reduce overtime. So that's something we'll measure. And then we also need to measure impact so that we know that we're not hurting ourselves instead of helping us. I suggested we monitor things like patient complaints, wait times in the waiting room, how long it took patients to get appointments, and then some of the financial measures, so how fast are we dropping claims so we're getting paid and things like that. And so the next time I came back to the hospital, he had his goal set to reduce overtime and wasn't measuring any of the things we had discussed. And the first time he knew that he had a problem was when he went to a board meeting and the board confronted him on all the complaints they were hearing in the community on inability to get an appointment, sitting in the waiting rooms, all these things that he was not measuring. He was only measuring how many FTEs he cut in terms of overtime. And so he didn't last in his position much longer than a year because he created this perception for himself that he was saving the hospital money, when in all reality, he wasn't, because patients had started migrating to other clinics associated with other organizations. So they were losing enough volume and they were losing enough staff over the situation that when you did all the math, it was a net loss. And we have a lot of that going on in healthcare right now, especially because we're in a situation in healthcare where everybody's so worried about money that and our habits are the habits like I just described. We're losing more money than we're making when we are actually trying to save money. It's like one of the hospitals that I used to do some work with, and the CEO decided that he was going to save money by getting rid of the quality director and the risk manager. He was going to save the money of those FTEs, and he was just going to have the nurses do it. The nurses could just manage all the incident reports, manage all the quality responsibilities, manage all the survey readiness. And it became a pretty ugly situation when on the hospital's next survey, they got one of those ugly little notices from CMS that said, you got 10 days to clean this all up, or you could lose your ability to bill Medicare. And so they lost an enormous amount of money and time because he was focused on the kind of little quality that has always worked against our hospitals.
Do you think that some of this goes back to the concept that quality cannot be quantitatively measured? So there's no way to really show if it's actually helping you?
I think it goes back to a belief that in healthcare, what we don't know helps us. I think there's this long-standing belief that if we hear of no problems in our building, we see no problems in our building, and we discuss no problems in our building, there can't be any. And so we have phenomenally weak data collection and management processes in healthcare right now. And then when we do collect data, we collect it in a way that it's very hard to have it tell us anything meaningful. Or a lot of times I see organizations, if they don't like what the data is showing them, they're still engaged in that old school behavior that says, well, let's repeat the study. Let's recollect the data and make sure that it's telling us that before we do anything about it. That's why we can have problems in healthcare that can last years, not just months, but sometimes years, because we don't collect data in efficient ways. We frequently don't collect the right data. And then when we have the data, we do this game of procrastination on what we're going to do with it. And so every day it just gets uglier and uglier and more costly for us to manage things, because instead of just recognizing we got a problem, getting on top of it and fixing it so that it's really fixed and fixed in a sustainable way, we just play this game of procrastination that historically seem to work for us, but is a big reason why the industry's in the mess it's in today.
So, talk a little bit about managing money and quality like they're two sides of the same coin. What does that mean?
So, one of the things that's really important for us in healthcare right now is to understand that money and quality are inseparable. We cannot continue to try to manage money and not be on top of the quality things that impact how much money there'll be and how we get to spend what money we have. And so it's an extremely important concept. So let's talk about the balanced scorecard. Kaplan and Norton introduced the concept of the balanced scorecard several years ago. The idea behind it was you cannot make yourself healthy as an organization unless you're willing to manage activities in four major areas: financial numbers, customer numbers, operational numbers, and learning and numbers. Constantly growing our staff, helping them stay current with what's going on, constantly growing our cultures in a healthier direction, something we talked about on a previous podcast. So they introduced this concept where you take critical measures. Let's say you're going to implement a new service. You take critical measures in the areas of financial gains and management, customer satisfaction and meeting customer expectations, operational efficiency and effectiveness, and then workforce growth and learning. And then you monitor a handful of numbers in all those areas to get yourself to whatever your strategic goal is. It's about strategic alignment with operations. Now, that's not how we used it in healthcare. We actually butchered the concept way too many times, but it's a critical one for healthcare right now. You cannot be implementing a new service or implementing a new piece of equipment and just think if you put it in place, the patients will magically come and they'll be happy. And so the balanced scorecard is well, they didn't talk about it in terms of quality. That's what the balanced scorecard is about. It's about taking our financial numbers that we want to improve now in healthcare and figuring out the operational and customer numbers that we need to monitor and we need to use to help us get ourselves to the financial benefits we want. I see this happen all the time in hospitals when they open clinics. So they open a clinic and the goal is to make money. So in the beginning, they do really good making patients happy. So they attract patients from other clinics because they don't have a lot of volume. They can get patients get right in and get an appointment. You call in to get your prescription refilled and somebody answers the phone right away or gets right back to you. We do everything extremely well to make those patients happy, but it's because we do not have the volume to have to do that in a more efficient and effective way. And because a lot of times hospitals will open these clinics and they track nothing when it comes to those things that are important to the patients and important to efficiency and effectiveness as their volumes grow because they build a reputation for being able to meet patient needs. All of a sudden, you can't get an appointment so easily. But nobody knows how long it takes a patient to get an appointment. You can have to call 6 times to get a prescription refill taken care of. You can call and never have the provider call you back to answer a question you have. So what happens? Because somebody else over here has now opened a new clinic that has the benefits of meeting patient needs because of low volume, patients start migrating in the direction of that new clinic. And this is a story that plays out over and over and over again in healthcare because nobody manages quality as the second side of the coin that they're chasing. And so everybody's just got to step back and say, so what do I need to know? What from a quality perspective do I need to understand in order to be able to um, achieve the strategic goals that I've set? There's no sense in opening a new service and setting these big strategic goals unless you are going to manage that service with the goal of making them happen. And all of that lives inside our quality activities.
So it seems like today things are worse than ever, just based on my personal experience between trying to make appointments for myself or my children. It seems like getting phone calls back, scheduling appointments, follow up, and not in all cases, but in a lot of cases, it's difficult and you have to really police your own care to make sure it's happening. And from my perspective, it seems like this is happening because of the issue with staffing and turnover and the shortage in healthcare workers that everybody's just kind of trying to get through the day and get as much done as they can. So is that the case? And if it is, how do they move to a higher level of quality when they're just trying to survive from the perspective of getting things done with a shortage of staff?
We have to start addressing all the things we've talked about over this series of podcasts. We've got to now start moving in the direction of a just culture because it's critical to us now retaining staff and attracting staff back. No one's coming back from the other positions they have until we internally fix what drove people out of this industry. We've got to embrace a type of systemization that we've never operated with in healthcare because we've always treated all this stuff as an incidental to saving money. And then we've got to do some of the things we're talking about today. We've got to really start managing money and quality like the two sides of the same coin. We need to use quality to protect the money. Because right now, we're just all over the place. It's like this morning, I was on the phone with a hospital before we just got on to do this podcast. And this is exactly what we're talking about, is the fact that they feel overwhelmed. You know, you got all these players out there wanting to help us. They're creating more numbers that we have to collect and report. They're creating this, they're creating that. And nobody's sitting down and saying, so what's the big picture strategic goal and impact of all this? And until healthcare organizations decide to do that for themselves, this isn't going to get any better. Patients are going to be more unhappy. Patients are going to be enticed to consider looking for other avenues to get their health care. I mean, I think that's something that we're now at a point in healthcare where we really have to think about is the fact that corporate America wants answers to our healthcare issues. And they are trying to come up with them on their own. And we just keep poo-pooing that idea. I've had this conversation, I can't tell you how many times with healthcare leaders, and they say, well, they can't replace us. They can't replace us. We're healthcare. And I look at them and I say, why can't they? If they can figure out how to improve access, improve outcomes, and reduce the cost of healthcare, what compelling reason is there for anybody to continue to defend the existence of the current healthcare system? And they're going through this phase that Jim Collins describes as the trial and error of competition. All right. They keep trying. They'll push something out there. And we've seen that happen. Walmart's pushed something out there, didn't quite work. So they backed off. And we read into that they will never figure it out. They will never figure out how to replace healthcare. So you know what we do? We don't do anything to prevent that from happening. And so if you look at other corporations who used to be big players and now don't even exist anymore, what happened is little corporations or little players kept chipping away, looking for answers to get into a market that the big players refused to regulate for themselves, or they refused to fix for themselves. And with enough time and enough effort, they figured it out. They figured out how to undermine Kodak. They figured out how to undermine all these companies that when I was growing up were big players. They were perceived to just be invincible. But nobody's invincible when you cannot meet the needs of the buying customer. And that's kind of where we are at right now. The patients are becoming increasingly upset. Businesses are becoming increasingly upset because they can't get their own employees can't work because we're sitting around waiting for healthcare to take care of stuff. And we now have to step back and we have to figure this out. And nobody's going to figure it out for us. The regulators aren't going to figure it out. The insurance companies aren't going to figure out. They all got issues of their own that contribute to this mess. And because they're not willing to fix themselves, they can't help fix us. But we as an industry have to decide we're going to step up to the plate and now start practicing a kind of quality that helps us make things work for us and work for our patients. And so it's like, I believe you were telling me the other day how you got a phone call. And it's some woman on the line, and she says, Amazon has a physician who could help you manage your care if you need one. And I've had 2 other people tell me they got similar calls. Now, I suppose they could be spam or some sort of a scam, but the fact of the matter is, it's probably not that easy to dismiss that concept, because what's the biggest issue right now is getting a physician appointment in a timely manner and having somebody actually act like they care if you have good outcomes. So we need to step up.
Yeah, I did. It wasn't a phone call. It was an email about the Amazon provider care that they now offer virtually that you can go to. And based on how hard it is to schedule certain appointments anymore, it does seem like people are going to go towards that route if we can't figure this issue out. So where do we start? What do we do to try to work through this issue in a realistic way?
We have to start retooling our quality and risk management programs to make it easier for us to manage the expectations and needs of our patients. We use our quality programs to help us find all the inefficiencies and ineffectiveness that lives in our organizations. We take better control of what creates risks inside our buildings. Here's a great example of that, because this just happened to somebody. So this gentleman was experiencing chest pains in his chest. So he went to his doctor. His doctor referred him to a cardiac specialist. The cardiac specialist said, well, we better do an angiogram and just see if you've got occlusion in there and if we need to do anything about it. So he went in, he had a cardiac angiogram, which showed that he had 80% blockage in his major arteries. So all of a sudden we got this crisis. He's got to have surgery. We get in there, they do the surgery, and they can't find any occlusions. They can't find any blockages at all in his coronary arteries, except for a couple of very small ones in some of the more peripheral arteries. So in the end, they didn't do anything, okay? But in the process of all of this, here's what happened to him. He went in and he had that angiogram. And they did it through a transradial access in the arm instead of the way we used to do it through a femoral access. Studies show that it's safer, that it's easier on the patient, and things like that. But he had it done that way. So afterwards, they went through all the steps of, slowly releasing the pressure on it so that it would clot off and that he would not have bleeding problems. So when he got ready to leave, he's walking down the hallway with his wife towards the parking garage. And she says, all of a sudden, blood started spurting all over the place. It was on her, it was on him, it was on the floor. She said she's yelling for help. They were almost to the parking garage. And she's yelling for help. And the parking attendant, who was within earshot, says to her, "I'm sorry, I can't help you. That's not my job." And so she keeps yelling. And finally, somebody stopped to help her because some other patient and their family ran to get help. All right. The nurses showed up, got him back to the cath lab, and got the bleeding stopped and sent him home. So now here's the critical question for healthcare. If that happened in your organization, how many of those events would get identified, investigated, and addressed to minimize the chance that they could happen to another patient? Or are you the kind of hospital that would just say, well, you know what? Stuff happens. We have statistics that show us how often we should be doing procedures and not finding what we went in there looking for, like an appendix. And that's part of the safety practices of protecting patients. But we should still look at them. How can you do an angiogram, have an 80% occlusion of the major arteries identified, and get in there and find nothing? So are we going to look at that and we're going to figure out how it happened? And are we going to internally take steps to minimize the risk that could happen to another patient? Or are we going to sit around and wait for the payers to do it? For the payers to decide, we're not paying for procedures that don't produce results, aren't necessary, and so we're just going to ratchet back on how we pay our hospitals, potentially increasing the risk of harm to a patient, not reducing it. All right? Are we going to look at that kind of stuff internally and figure out how to fine-tune our own processes so we don't need outside help? Are we going to wait till some patient makes it partway home in the car and starts to bleed out like that and may die? So are we going to wait for that to happen and then have the feds come in or the investigators come in and end up with a medical malpractice claim? Or are we going to look at that and figure out what we could have done different, or if we needed to do something different to minimize the risk it could happen? Are we going to do something about a parking attendant that says it's not his job to help a patient who's in distress? But see, this is the problem we have right now in healthcare. It's like a conversation I just recently had with a hospital, because no matter how hard they try to satisfy all these little quality projects that are floating around out there and satisfy all these numbers that they're now required to track and report on as part of all these projects, their quality reputation in the community isn't getting any better. It's getting worse. And it's because there is never going to be a project big enough to do for us what we need to be doing for ourselves. And that is getting control of the environment where we deliver patient care, identifying our risks ourselves, not having to have a rule or regulation that says we have to identify that risk, and getting control of what hurts us and hurts our patients and hurts our staff. Because until we decide to do that, if we built a project in this country big enough in order to encompass everything, all the risks that we need to be in control of, no patient would ever get any patient care because of the resources these projects consume. Resources that could go back into the delivery of patient care if healthcare decided to get control of its risks on its own. Because we would do a far better job on our own than these projects are doing. I mean, if all these projects had to come up with the data tomorrow to show how many lives they've saved, how many risks they've reduced, how much happier the American people are with the care they're receiving, I'm afraid of what those numbers would look like. And so we need to decide as healthcare providers to step back. We have to understand the relationship between money and quality. And we've got to use our quality programs to help us manage the money because it is a reciprocal relationship that is inseparable. I remember one time going to a hospital. They had gotten themselves into some trouble. And so when I go into a hospital for the first time, I always meet with the senior leadership team. I like to understand their perception of what their quality problems are, what their quality program is, because like I keep saying, this starts in the C-suite. And so then after I meet with the senior leadership team, I start meeting with different managers and trying to get a lay of the land as to what's going on inside the building. So after I got done meeting with the senior leadership team, the CFO followed me out of the room. And he stayed with me all day, moving from department to department to department, meeting with different managers, look at the different processes and things like that. So I was going to be there for 3 days. The second day I showed up, he's standing there in the lobby waiting for me. And he went with me and spent the whole day again, walking the building, understanding, the conversations about quality, risk management, and operational performance and money. So the third day I got there, I walked in and he's standing in the lobby. And I looked at him and I said, I decided if you were standing here this morning when I got here, I had died and gone to heaven, but nobody told me yet. I said, because I have never, ever had a CFO take this kind of interest in what I do in a building. And he just looked at me and he said, but you know what? For the first time, I understand that there is a relationship between money, what I'm responsible for managing, and our quality activities in this building. He says, even when I went to school for fiscal services, he says, I was told that there's no relationship. There's no relationship between money and quality in healthcare. My job's to manage the money. The quality director's job is to manage quality. He says, I'd never heard the 110-100 rule. I'd never heard all this stuff you talk about how money aligns with quality in a service industry like healthcare. And see, we need a lot more CFOs getting it because they have a lot of power in our buildings to make quality stuff happen and to explain to people. One of the other podcasts you asked me how we now get people to buy into this, because for 50 years, we've been telling our staff this is a game we play with the regulators and the surveyors. It's not important. You only have to do this stuff long enough to get through the survey, and then it doesn't really matter if it happens again until the surveyors are going to come back. The CFOs are very powerful players in our buildings. And if they get how quality and money align with one another, they lend a powerful voice to the CEO and the directors of nursing to sell this to the staff. And so we just now have at the C-suite level, we need to see people having those conversations.
Yeah, they can really make or break a quality program and the success of it for sure.
You know what frightens me right now is I still see way too many who keep dismissing the importance of quality. They're running around, cutting staff, cutting this, cutting that, and they have absolutely no idea if they're actually making things better or the damage they might be doing. And until they figure that, until they have that wake up call, it's like that CFO that I was asked to work with. He didn't even survive his position for a year or about a year. And you know why? Because he just kept slashing and burning, thinking he was helping the organization, when in all reality, he was driving patients away and he was creating costs that had not existed in the past. So quality is all about money. If you can't make the patients happy, you can't control your wasteful costs and your unnecessary losses, and you cannot drive a level of efficiency into your organization beyond the mess that exists today. It's kind of like healthcare looks like this big fibrillating heart. There's lots of activity, but there is no hospital saving blood pumping through the hallways of our buildings. And it lives in an understanding that quality and money have to be managed like they're two sides of the same coin.
Yeah, I agree. I also think they need to get comfortable with change, right? And part of this with quality and the way that healthcare changes, you need to be comfortable with change. You cannot live under the philosophy that we have done this way forever, so we're going to keep doing it that way.
I agree. Totally. 100%. If you can't change, you got to find someplace else to work. That's the new philosophy in our hospitals. We got to stop clinging to this idea because we have a staffing crisis. We have to tolerate our poorest performing employees, the employees that drag us down. And we've got to now set our quality standards and live by them. And if you don't want to help us make those things happen, then there's someplace else you could work. But we need to put somebody in that slot who's going to help us make it happen. I mean, I get an opportunity to talk to a lot of healthcare staff, frontline staff that take care of patients. What I found is there's a lot of them out there that would make that move. They would do whatever it took to make sure their patients had a great experience. If they did not have to worry about being thrown under the bus or somebody who doesn't want to change having the power to retaliate against them. I mean, I have people sometimes, every once in a while, I'll get a call from somebody and they'll share something with me about something that they think needs to change in a hospital. And I'll say, okay. I said, well, why don't you go talk to so-and-so about it? Oh, I can't. If you suggest it, it's different, but I can't because I'll probably get in trouble for saying it. As long as we have people in our buildings who are afraid to speak up and tell us when we could do something better, when we could do something to make our patient care safer or more attuned to a patient's needs, this is not going to get any better. It's like a conversation I recently had with a place. They had transferred a patient to a larger tertiary care facility. So because they couldn't meet his needs, he really needed to go to a tertiary care facility. So they sent him there, and typical of what's going on right now in healthcare, the tertiary care facility doesn't have enough inpatient bed space. So this guy spent 5 days in hallway on a stretcher. But he got treated. And then when he got discharged, he came back to the hospital that had transferred him out because he was going to need some additional care before he could go home. The patient got back to the hospital and he says, "Do you think you could help me get cleaned up and change my clothes?" And they said, "Sure." They said, "Well, why?" And he says, "Because I haven't gotten cleaned up in 5 days. I still have on the underwear and the socks that you transferred me in." He says, "I've been in them for 5 days." And then we want the American people to feel sorry for us, to feel sorry for how hard we work, how overwrought we are. It's not gonna happen. Alls we're doing is we are opening that door wider and wider and wider for companies like Amazon and Walmart to figure out how to do this stuff better. And if we think as an industry they won't figure it out, we've got a sorry future ahead of us. Because as the patient experience gets uglier, and a lot of those patients are their employees that they have to count on and that they're paying the insurance premiums on, if we don't think they're gonna figure it out, I got news for the healthcare industry. It may take them a while, but the question is, how long can we survive doing things the way we're doing it right now and not all of a sudden find ourselves in a situation where we are so far down in that slide of what Jim Collins describes as grasping for salvation, there is no saving us because the money won't be there to pay for what exists, and corporate America or somebody will have figured out how to take the money that we get and spend it smarter.
So, before we wrap up today, is there anything else that you wanted to add or talk about?
I don't think so. I mean, I just want people to take the things we've talked about in this first round of podcasts we've done and start figuring out how to piece it together inside your organizations. We have a ton of low-hanging fruit in our hospitals. I mean, we don't have to work very hard at this to figure out opportunities to get more business smart, more defect free, more workforce focused, and more patient focused to make things work better in our buildings. But if we're not willing to do it, then the fact of the matter is it's just not going to happen because nobody's going to do it for us. We've got to start making this somebody else's fault. We've got to stop blaming the infamous they, and we've got to start figuring out how we're going to do this on our own. And then I would strongly encourage folks to go out. If you haven't already read Jim Collins' book on how the mighty fall, I would strongly suggest you read it. And then we are presently putting a series of blog type pieces out on our website where I dig into the details of some of this stuff more thoroughly. And I would strongly encourage folks to go out there and read those things and figure out how you start doing some of this stuff that if we had done it 50 years ago, this industry would be totally different than it is today.
That sounds great. Well, thank you, Darlene. And thank you for spending this time with us. And I hope that you found this conversation interesting. And if you did, please make sure to subscribe to this podcast on your favorite platform. In addition, if you would like to learn more about us and what we do, please visit our website at qualitycalendar.com. And we hope that you join us on our next episode. Have a great day, everybody.